Hi, I'm Steve Selling, founder of FitTest, and the topic of this video is part 2 of a small series is on atrioventricular nodal blocks for exercise professionals. And in part 2 of this video, I'm going to continue to categorize AV nodal blocks and give you some guidance on indications and contraindications for exercise. And I'm also going to present one of my case studies. So first of all, first degree AV nodal block, just the feature of it is a prolongation of the PR interval, which is the interval between atrial contraction and ventricular contraction. Atrial contraction being the P wave, ventricular contraction starting at the QRS, and then you get the T wave. Now the reason why, well, first of all, the normal PR interval should be no more than one large square here, whereas in this example here, it's almost two large squares. So one large square is in the range of 0.12 seconds to 0.20 seconds. That's the normal PR interval. The reason why we don't like it prolonged is if the atrial contraction is coming early, then it's really interfering in a way with venous return coming back from, in the case of the left ventricle, the lungs, or in the case of the right ventricle, the superior and inferior vena cava. Now, we don't want that contraction to come too early because it will interfere with that venous return, which normally passively and very effectively fills the ventricles, even in exercise. So the ideal, the sweet spot, if you like, for the PR interval is in that range of up to one large square. Here it's almost two large squares. Now, we can proceed with caution according to the guidelines, even up to VO2 peak. But you're going to see in this video that I'm very cautious with all of the levels of AV nodal block. And the reason I am in general with AV nodal block is this demonstrates a block, an electrical block in the AV node. And if it blocks more during exercise or becomes very significant during exercise, the ventricles can take up the rhythm and then we're in all sorts of trouble. So we certainly do not want the ventricle taking up the rhythm in exercise, such as in ventricular tachycardia or worse. The other thing I would say is if I find a new AV nodal block of any severity, I will report that to the primary care medical practitioner. Mostly it's not urgent, but it's, I guess, semi-urgent. In the case of third degree AV nodal block, it certainly is urgent, but the others, it's not necessarily urgent, but I report every one of these that I find. Now, another thing you can do is AliveCor has actually provided a really good system, and in handheld ECG, single channel ECG, as you can see here, and you can pick up the conduction defects very easily with a handheld device, no electrodes on the skin. There's a free Cardia smartphone app that goes with this, and this is a simple and inexpensive device that can help you as an exercise professional to identify all sorts of arrhythmias, but also what we're talking about here, conduction defects such as AV nodal block. So coming on to second degree AV nodal block, or Mobitz type 1, what happens here is there's a gradual prolongation of the PR interval, you can see for the first 3 beats, followed by a dropped beat. Now you'll notice that all the P waves are evenly spaced, even the 4th and the 5th one. So the P waves are in rhythm with a gradual prolongation of the PR interval until there's a drop beat, and then the pattern repeats. So you need to see a longer rhythm strip than what is shown here to be really convinced that this pattern is repeating. Now again, caution with exercise and report back if it's a new finding, report. Again, you could pick this up with the AliveCor system very easily. I'm suggesting that you only proceed with exercise up to moderate intensities and don't go beyond that. But really that's your choice because it's not an absolute contraindication to exercise. But in my own practice, I'm going to restrict this person to moderate intensity exercise only. For second degree Mobitz type 2, what happens here is the PR interval can be normal in this case, or prolonged, not shown here, with dropped beats. Now the important thing is to discriminate between this rhythm and just say a non-conducted atrial ectopic. Now in the case of, to be convinced that this is second degree AV nodal block Mobitz type 2, we have to know that the PR intervals are constant, and that's what is happening here. The P to P intervals here are all evenly spaced apart, including this one here with a drop beat. If this was a non-conducted atrial ectopic, this P wave would shift this way. It could shift all the way onto the T wave or back here. And then that would tell us it's a non-conducted AE, which is a very different scenario altogether. So that's an easy way to discriminate between a non-conducted atrial ectopic and second degree AV nodal block Mobitz type 2. Again, same guideline, caution and report, moderate intensity only. Now we come to a variation of second degree AV nodal block. This is where the level of block is extended to where every second beat is non-conducted. But again, these are not atrial ectopics because the P to P intervals are constant throughout this record. You can measure it out yourself. These P to P intervals are constant. So this P interval and this one are all falling at the expected time. So it's not a non-conducted atrial ectopic. Again, very important to discriminate. I would not exercise this person because basically we've got a ventricular rate that is half the sinus rate or half the atrial rate. And I'd be really worried here whether this person would initiate a ventricular rhythm under exercise conditions. I mean, certainly they could do, you could argue that they could do light intensity exercise, but when I find this in my own practice, I do not exercise the client, and this becomes a semi-urgent referral back to the primary care medical practitioner. Now we come to third degree AV nodal block, and in this situation, what is happening is the P waves, which I'm just pointing to through here, are still at a constant rhythm. So the P waves are evenly spaced apart. So there's nothing per se wrong with the atria or the sinoatrial node per se, but the ventricular rhythm is completely independent of the atrial rhythm. And in fact, the ventricular rhythm now is coming from the AV node, but not through the atria. That's important, coming from the AV node, but not through the atrium. We call that junctional escape rhythm. I definitely would not exercise them, and I would report and refer. Now, you'll see here that high degree AV nodal block is on the American College of Sports Medicine list of relative contraindications, which means you can proceed with caution. As I said at the beginning of this video, I'm very cautious, probably maybe overly cautious with all of these AV nodal blocks, and I really have a higher level of caution than the American College of Sports Medicine because I worry about ventricular arrhythmias occurring when you go to exercise these people. So technically, with high degree AV nodal block, which incidentally is not defined here, you could exercise them with caution. I prefer not to exercise these last two categories here. Now we come to my client presentation with hypertension in 2006, myocardial infarction in 2009, diabetes, type 2 diabetes, diagnosed back in 2014, ongoing diffuse coronary artery disease on further scanning investigations, and recent feelings of arrhythmias or palpitations. The medications that we use, I'm just listing the cardiovascular ones here. Perindopril, anything ending in pril, is an angiotensin converting enzyme inhibitor used to treat hypertension and heart failure, but we don't have evidence of heart failure here. Amlodipine, anything ending in PINE, is a calcium channel blocker. Again, the indications for this case are hypertension. Atorvastatin, the statin is used to treat hypercholesterolemia and also to stabilise coronary artery plaque because there is ongoing diffuse coronary artery disease. aspirin used to just defend against intracoronary artery thrombosis. So it's just given as background medication here. Glycerol trinitrate, GTN spray, is given if the person did develop acute chest pain, especially on exertion or stress. And now we come to what happened in relation to the referral to me as an exercise physiologist. I found at rest, although the resting heart rate was fine at 70 beats per minute, on ECG, I was able to record a lot of dropped beats. So this one, here, and here, and here, and here. So lots of dropped beats. So although the ventricular rate looked satisfactory at 70, clearly you can see that there's a ventricular arrhythmia going on at rest, and on ECG, careful examination of the ECG, and you'd only need a single channel ECG, although I had a 12 lead ECG here. You don't need that. A single channel such as a live call would have picked this up very nicely. And what this is showing is normal PR with constant PR where there are waves, but lots of drop beats. So this is diagnosed as second degree AV nodal block Mobitz type 2. And I referred back to the primary care medical practitioner. And in this instance, I proceeded with exercise with caution. I had to go to a different lead in exercise that was clearer signal. The peak exercise, I restricted this exercise test to moderate intensity, and peak exercise was 90 to 120. But I'm not happy with the number of drop beats here, and I'm not happy here that the heart rate was pointing towards going to a much higher rate, albeit in rhythm, but a much higher rate. And so I stopped exercise early in this client and referred back. And there's no medication to be given for this. If this level of AV nodal block continues to progress, this person will be treated with a pacemaker. That's the only really successful long-term treatment. But in the meantime, I could proceed with exercise carefully up to moderate intensity only. This is not a candidate for high intensity training. Just be aware of that. So thank you for listening to this part 2 presentation on AV nodal blocks and the case study that I just presented. You can contact me at info@myfittest.com.au and have a great day. Bye for now.